I want to thank all of you for joining us for the Program Planning Committee speakers and sponsors, and especially you, the attendees. This program is a result of the energy and generosity of many people, and we're so glad that you're here with us today. A couple of reminders: the session is being recorded. There's live transcript, closed caption at the bottom. If you would like that, you can also turn that off in your Zoom settings if you prefer. A follow-up email will share the link and the resources that we talk about today. So no need to take notes or worry about it. You'll also get the link to watch the recording to listen to the information again. And we encourage you to fill out the survey at the end of the webinar. There'll be a drawing after a week for a $50 gift card of all the people who filled out the survey. So that's a little additive incentive, but mostly it helps us improve programs and see what you want to learn about in future sessions. Important reminder that the medical professionals that are speaking today are qualified, but it's really important to seek the advice of your own healthcare provider about your personal medical situation. And we're using the chat box today. And for both questions and comments, we encourage you to put all your questions in there. And if you want to warm it up a little bit right now, you can tell us where you're coming from. Make sure that you choose everyone on the drop-down box in terms of who gets to see your questions and comments. And we look forward to answering as many of those as we can. If we can't get to them, we will prepare a document and share the rest of the answers in the follow-up email. And I just want to remind you that we have lots of resources other than webinars to support the community. I urge you to access these, and we'll also share the information for these in the follow-up email. And I want to thank our presenting sponsor, Satellite Healthcare. We've been partnering with Satellite for decades, and through their volunteer energy, we have walk teams and presenters and committee members and attendees, and we appreciate their partnership over the years. I realize I didn't even introduce myself. My name is Patty McCormick. I'm the Senior Program Director for the National Kidney Foundation serving California, Oregon, Nevada, and Washington. And I am so excited for this group. We have many, many people registered. It's a huge interest. We have great speakers and a fantastic panel. I'm very happy to see all of the people logging on. I'm going to pass this over to our Executive Director, Amy Hewitt, for a few words before she introduces our Satellite Healthcare partner.
Hi, everyone. Good afternoon. Thank you all so much for joining us for today's very, very valuable session. And Patty, thank you so much for that kind introduction and all the info. I'm Amy Hewitt. I'm the Executive Director for National Kidney Foundation. Our office serves California, Nevada, Oregon, Washington. I've been with NKF almost 3.5 years. And I know almost the half year because I celebrated my 3rd work anniversary by becoming a living donor. And I'm just 5 months out from that. I was part of a 4-period exchange at UC Davis this past March. So today's topic is very near and dear to my heart. I'm very passionate about bringing education to our community on this very complex topic. And I'm deeply grateful to all of our speakers and panelists for giving their time and expertise for the benefit of our community. And as Patty mentioned, I'm also deeply grateful for our partnership with Satellite Healthcare, today's presenting sponsor. And I'm really honored to introduce Emily Watson, Director of Social Work at Satellite Healthcare, to say a few words.
Thank you so much, Amy. I'm really honored to be here as well, and for Satellite to be sponsoring and partnering again with the National Kidney Foundation. We work so much towards the same goals in supporting patients living with kidney disease. So as a nonprofit dialysis organization, Satellite truly does support the goal of our patients, those working towards transplant. And a program like today's, a program supported by the National Kidney Foundation, is something that I look forward to. I am proud to be a part of this, and I'm very excited to hear from these panelists, and especially from Kevin, and hearing about tips on how patients can better manage being on the wait list, but certainly hearing the success stories. Being a social worker, I am the Senior Director of Social Work for Satellite Healthcare, and being a social worker working here in the kidney space for 17 years, I have supported many patients and watched many patients work through the challenges, the barriers, and certainly reaching the successes of a transplant. And so a program like this is absolutely fabulous to support those continuing on their journey. And I thank the National Kidney Foundation for putting this on. Thank you for allowing me to be here. And I look forward to hearing the rest of this program. So thank you for partnering with Satellite.
Thank you, Emily. It is now my pleasure to introduce our next speaker. Kevin DiCipolo is the transplant manager at the Stanford Healthcare Kidney and Pancreas Transplant Program. He's been with Stanford since December 2015 and Satellite Healthcare before that as a clinic manager. He lives for the care of those in need, advocating for patients and their care partners, and building strong relationships with healthcare professional colleagues. He's committed to providing compassionate care with a personalized touch and educating people to empower them to live longer and healthier lives. And I happen to know, I believe he's a father of 3, so he gets kudos for that too. Take it away, Kevin.
Well, thank you so much, Patty. Thank you so much, Amy. Thank you so much, Emily. And thank you to the NKF, and thank you to Satellite Healthcare for this event. It's certainly near and dear to my heart. All I've known in terms of my nursing career is working with patients with ESRD, or patients that are very close to approaching ESRD. So very, very thankful to be a part of this event. It almost feels full circle, because I recall being a part of the NKF symposiums and seeing education like this, and it inspired me to want to pursue a career in transplant. So with that being said, I'll go ahead and share my screen here. As Patty shared, I do have a family of 3 children, so apologies if you hear some in the background. I did tell them that I was going to be doing a presentation for all of you. So just let me go ahead and start the presentation on my end. Okay, can everyone see the screen? I just want to make sure. Okay, great. Thank you so much. So the topic of discussion today is understanding the kidney transplant process. I am from Stanford Healthcare, as Patty had shared. So I am affiliated with them. However, I will try to do the best I can to keep it as generalized as possible, because I know that there's many people on this event that are from all over parts of the United States. But I'd say for the most part, a lot of this information will be applicable to you. And if you are pursuing kidney transplant, of course, there's going to be an opportunity for you guys to ask questions at the end as well. So let's go ahead and get started. So some things to know before you pursue kidney transplant. Getting evaluated by the Kidney Transplant Center may depend on the types of insurances and resources that you may have. This is even before, you schedule an appointment. Sometimes patients will be routed to specific transplant centers depending on what type of insurance you have. Just as an example, at Stanford, if a patient has Medicare and they live locally, they will be routed to us. However, if they have Medicare and they live in a different county, they may be routed to another center that is close by to us, which is UCSF, CPMC. It depends on the type of insurance they may have. Of course, if you have the financial resources to do so, you actually can list at as many multiple locations for kidney transplant. We'll get to that later, though. But just so you are aware, just kind of if you are eyeing a particular transplant center, there may be some limitations. Next is each transplant center is different. So a lot of the big questions that sometimes patients ask, even during the scheduling phase, is this workup that I'm doing at XYZ center going to be applicable to ABC center? It actually, sometimes it is, sometimes it isn't, but for the most part, you're going to have to go through the evaluation process with that center in order for you to be listed on that center's wait list. Each center will also have their own absolute and relative contraindications. Prior to this event, I actually just made sure to review the United Network of Organ Sharing policy regarding wait listing, and there is no hard absolute relative contraindications that that is, applicable to every single center. Every single center actually has their absolute and relative contraindications. And if you actually happen to Google that particular thing, you're going to find that each center has their own way of, acceptance criteria. As an example, absolute contraindications could be active cancers. If you have active cancer, pursuing transplant may not be possible at that time. Relative contraindication would be weight. So for example, at Stanford, we do have a BMI cutoff of 35, a BMI of 35. Now, what BMI is a calculation of your weight and height. If that calculation is 35 and less, then we will actually, I'm sorry, if it is a BMI of 40 and less, we will be being able to list you on the kidney transplant waiting list at Stanford. There's also further, each center will have their own absolute and relative contraindication. So it would be good to actually look into that information. Each center should have that. Of course, very important, waiting times for deceased kidney transplant will also be very different from center to center. Again, I'll go into that a little bit more as we go along. And of course, the living donor workup will also differ from center to center. Kidney transplant is not a cure for kidney disease. It's just another form of treatment, much like how dialysis is another form of treatment for kidney transplant or for kidney disease. I suppose, in terms of diseases, for the other solid organ transplant organs, the other organs are actually life-saving. Kidney transplant is not necessarily life-saving because there is that alternative treatment. So just some things to know before you pursue kidney transplant. So just to start off, the kidney transplant evaluation process starts like many journeys in healthcare, where you are being, a referral is being sent on your behalf, or you are contacting the center to request to be referred to be evaluated. So on a typical referral form, you're going to be being asked of your full name, date of birth, social security number, most recent history and physical from your local provider. Typically, it is a general nephrologist or a local nephrologist that you work with. Most recent labs that would show your current kidney function, and a 2728 form. And so for some of you that are not yet on dialysis, or even for some of you that are on dialysis, not sure what a 2728 form is, essentially a document which is what we at transplant centers utilize as a kind of gold standard for us to be aware of when you started chronic dialysis. So that is kind of the document we use to verify when you started having to do dialysis ongoing. So I'll go into why that would be important in the next few slides. So once the referral is received by the transplant center, they do review it. For the most part, we try to do the best we can to get to as many patients as we can in terms of evaluating them. However, it is quite an extensive process in terms of getting financial clearance and proceeding with scheduling. So just know that sometimes patients are not contacted immediately because there are some things kind of going on in the background before the centers will contact you. So the kidney transplant team will contact you and schedule an appointment. Once the scheduled appointment is in place, there's a couple of things to look forward to in terms of that appointment. In order for you to actually be cleared to be placed on the kidney transplant waiting list, you actually need to be cleared 3 ways: medically, psychosocially, and financially. So medically, of course, it'd be performed by the physician and with assistance from the nurse. The psychosocial aspect would be covered by the social worker. And the financial clearance would obviously be performed by the transplant financial coordinators from that center. In the medical side, it would be the physician and the nurse's duty to determine if kidney transplant is a safe and reasonable procedure for you to pursue. A lot of the issues that we tend to find and we do have to talk about is cardiac status, will your heart be able to sustain a kidney transplant surgery, and also the care of the surgery and perfusing the organ? Apologies for the background. Perfusing the organ when it is now transplanted. Vascular clearance. That is a aspect where the surgeons are very concerned about where can this new organ be placed. If there are issues with your vascular status, then there may be issues with blood circulation to your lower extremities. And then, of course, cancer. If you have any active cancers or any cancer treatments that are still ongoing, then you may need to have a waiting period before, following the completion of your treatments, before you can then further pursue kidney transplant. From a psychosocial aspect, the social worker's job is actually to assess for mental and emotional readiness for transplant, to make sure that they have caregiver support, that you have housing, that you have transportation, all those wonderful questions that people tend to not want to ask because they are sometimes difficult questions to ask, but are very important and key to the periphery and success of a kidney transplant. So that's essentially what the social worker is trying to assess. And then lastly, financial. Of course, for the evaluation process, in order for us to proceed, we do need to get clearance from your insurance or have the funds necessary to proceed with the evaluation and the lab testing to be performed. But also further down the line, when you get closer to transplant, it would be making sure to secure financial clearance for the surgery itself, as well as the care after the surgery, follow-up appointments, medications that you would be needing to take for the lifetime of your transplanted organ, and any other additional testing or follow-up that you would need from a medical standpoint. So those are the things that we are going to be looking at during your kidney transplant evaluation appointment. Some testing and laboratory and diagnostic testing that would be performed during an evaluation. Again, each center will have their own requirements. Some examples would be blood type testing, HIV testing, Hep C testing, hepatitis B testing. They would want to know your creatinine or your kidney function, GFR, and then of course HLA typing. That's essentially testing for histocompatibility, and we acquire that information firstly because it's required in order for us to list patients on the kidney transplant waiting list, but also further down the line when you would be receiving kidney transplant offers, we actually utilize that information, that histocompatibility testing to perform cross matches with potential donor offers that would be coming down the line. So it's important to have that information, of course, to list and also to transplant. Other examples of diagnostic testing would be cardiac testing, potentially like an echocardiogram or stress echocardiogram, vascular testing, and cancer screenings. Those are just some of the testing that does occur. It really depends on the circumstances that you have, other comorbidities that you may have, and of course the center that is doing the evaluation. Next, so you've now gotten through the evaluation appointment, you've done the testing that is required by that center to proceed with your evaluation. What happens next? So after that, there is a required meeting that needs to occur, which we tend to call the Transplant Evaluation Committee meeting. So at Stanford, we call it TEM for short. I suspect that's probably another acronym that other centers may use. But essentially during these committee meetings, the provider that performed the evaluation, the transplant nephrologist that performed the evaluation, would actually be the presenter on your behalf, along with the nurse that was kind of helping you through the process. They bring up your case and then they actually present it to the rest of the transplant team, which consists of surgeons, dietitians, other social workers, other doctors, to decide what is the best way forward regarding your case for kidney transplant. And there are 3 potential decisions that would occur following that discussion: acceptance on the kidney transplant waiting list, denial, and deferral. Now, denial is something that does occur, and it is a requirement that we contact you or contact the evaluated patient to inform them why they were denied. You know, again, our physicians at Stanford, are pretty upfront about the evaluation. If there tends to be a certain issue that the transplant nephrologist is noting in your health and physical history and physical, that they would kind of talk to you about it. Again, so it's not, you know, I would say it's probably fair for you to even ask at the end of your appointment with the doctor, so am I a potential candidate? What's it looking like? And, you know, I would hope to find that your doctor would share with you kind of their initial findings and possibilities of getting on the kidney transplant waiting list. So if you are denied, then there isn't a reason for it, and they will be providing you that information, as well as sending communication to you via letter and notifying your dialysis unit if you are on dialysis, as well as notifying your referring provider. If you are deferred, that's not a yes, that's not a no regarding listing. It just means that we're deferring your case because we're not entirely sure how to proceed. We're likely probably be waiting for additional testing, that maybe there are some questions regarding vascular status or cardiac status, that we are waiting on a test that we have not yet received from an outside hospital, or maybe there's some testing that the patient may be working on to get done, and that we would like to see before we make our final determination. And then, of course, acceptance. That would mean that you are being accepted on the kidney transplant waiting list. Now, when you are placed on the list, there are two statuses. One being status 7, which is inactive, and which is not a negative thing at all, and active. Status 7, inactive, essentially means you're on the waiting list, you're accruing waiting time, but you're not ready to receive a transplant just yet. And that's just that most of our patients at Stanford, we list patients status 7, and when the time does come where you have enough waiting time points, or if you're nearing transplant because of living donation, that we make you active on the waiting list, which means you can receive a phone call at any moment, at any time, day or night. I try to stress that to patients because sometimes they're like, even at 2 o'clock in the morning, and like, yes, that's day or night. So, and that means you coming into the hospital and performing a surgery likely within the next 6 to 12 hours. So every center has their own way about managing the their kidney transplant waiting list. Some centers list patients active only. Some patients, some institutions list, like us, status inactive for a little bit of time and then become active. Again, we do the way that we do it in our way because of our workflows, as well as kind of the waiting times based in our region. There's no point in working up a patient for activation when they don't have enough waiting time, because 7 to 8 to 10 years later, they may need to perform the testing again. And the testing from 7 years ago may not be relevant. So we try to do the best we can to identify people that are closer to transplant and then working them up at that time. So when you're on the list, you also do have some responsibilities, of course. Cancer screenings, health updates, making sure that you're following up with your doctor to try to essentially stay as healthy as possible, and just accrue waiting time. During this time, we also encourage two things. If you do have the opportunity to multiple list, then you would be asking your physician to send a referral to another center to be multiple listed. What we do encourage patients when they are multiple listing, we encourage them to actually list at other regions outside other transplant centers outside of their region to help benefit to them. So, for example, at Stanford, we do share this region with UCSF and CPMC. So we ask them to actually, if you are interested in multiple listing, to list outside of the Bay Area. So the next closest area would be UC Davis. Sometimes we have patients that have family members and resources down in Southern California. So we do encourage that as well. But essentially, anywhere outside of this region would be applicable. And then also, once you're on the waiting list, that's actually when we really strongly encourage, if you happen to have a living donor, to begin the living donor process. Now, I'll go into that a little bit more once I get to those slides, but essentially, when you're on the waiting list, those are the things that you would want to be doing. Now that you're on the waiting list, also, so you're accruing waiting time, again, every hospital has their own estimation of waiting time needed to receive a kidney transplant waiting list. I would strongly recommend that if you are interested to know what your center's waiting times are, to go to this website. It's srtr.org. And that stands for the Scientific Registry of Transplant Recipients. And it's a center or a website and company that essentially we send information to as a center, and also it takes information from CMS to put information out there for the public to see that, what the waiting times are, what the estimated times of transplant are for those on the waiting list. Lots of great information for you. Each center will have that their information on that website. So strongly recommend to see what the waiting times are. For Stanford's purposes, just so that to kind of give you guys a little bit of insight, in the Bay Area, it depends on your blood type, and that's for every single area. It depends on your blood type what the waiting time is for. It can actually range between, in the Bay Area, about 6 to 10 years. If you're waiting for a deceased kidney transplant. Hence the reason why we strongly recommend living donation if you're able to do so. Kidney allocation for kidney transplant patients on the waiting list, it's again, a little bit, it is different for other transplanted organs, but for kidney transplant, it's actually based on a point system. Now there's different ways to receive points on the waiting list. But the primary reason that, the primary way and method that patients receive points on the waiting list is actually by waiting. So 1 year on the waiting list equals 1 point. That's why I kind of talked about those 27, 28 forms or documentation of when you started dialysis. Back in 2014, December 2014, there was actually something that a new policy that was put in place that individuals that were on dialysis before they were listed on the kidney transplant waiting list would actually be granted all the waiting time back from when they started. So, for example, let's just say we have Mr. Smith who has been on dialysis since 2015, but he's only been able to actually be evaluated starting today. If he happens to get on the waiting list, he actually, and has the documentation, the 2728 form stating that he started dialysis back in 2015, he is going to accrue all that waiting time. So his time will start back in 2015. So he'll now have 7 years of waiting time on the waiting list. For those of you that are, and for patients that are not yet on dialysis, if you get on the waiting list, that's actually when you begin starting your wait time. So if not on dialysis set and you get listed today, that's when your starting time for wait list would begin. More information regarding kidney allocation, there's actually some brochures that I believe the NKF team will be sharing with you. So UNOS is the United Network of Organ Sharing is actually the organization that is the umbrella for the wait listing, and we utilize them to get patients on the waiting list. So they have a lot of information regarding kidney allocation, wait listing. So strongly encourage you to go to that website and look at their resources. The last thing we talk about with patients regarding waitlisting and potential kidney transplant is the KDPI greater than 85% kidneys. Again, another acronym. Kidney transplant is lousy with acronyms. So KDPI, it stands for Kidney Donor Profile Index, and it is actually a consent form that we present to patients during the evaluation phase to potentially reduce their waiting time on the kidney transplant waiting list. Again, each center will have their own practice of this consent being offered to them, but essentially, what the KDPI greater than 85% consent form is essentially a document that states that you would be willing to receive a kidney that is scored as a KDPI greater than 85%. So you're wondering what KDPI is now. I've probably said it now 5 times, KDPI. So every donated kidney actually has a score attached to it. This score is calculated by a number of things. Some of it being the donor's age, the donor's comorbidities, the way that they have died, and so on and so forth. Again, more information, I would say, you can actually look into that on the unos.org website. Essentially, a score is calculated, and it actually speaks to the potential lifespan of a transplanted kidney. So typically, living donor kidneys are scored, pretty, again, they last a bit longer, and they don't really necessarily calculate into this KDPI, but they last a bit longer because there's more planning involved and care involved regarding living donation. So we'll get to that more later. But for deceased kidneys that score in the 0 to 20% range on average last about 11.5 years. They actually typically go to pediatric patients because pediatric patients do need a kidney that lasts as long as possible. So those tend to go to pediatric patients. KDPI kidneys that are scored in the 21 to 85% range are the typical organs that go to adults on the kidney transplant waiting list. Those on average last about 9 years. Now, the KDPI kidneys that are greater than 85%, there's actually a requirement that you need to sign a consent form that you would be willing to receive these type of organs. Now, you're probably wondering, why would I want a potential organ that only lasts about 5.5 years? It all really comes down to your circumstances. Just as context, at Stanford, we present this consent form to individuals that are 55, that have a longstanding history of diabetes. And also patients that are greater than the age of 60. So again, we try to do the best we can to, give the potential for patients to not have to wait as long as they need to. It doesn't guarantee that they receive a kidney transplant sooner, but if the patients are willing to receive kidneys that are, greater than the KDPI, greater than 85%, then, that is a potential kidney. I had shared with all of you that the waiting times are as such. They are 6 to 10 years of waiting. I can't even remember who I was 10 years ago. So, it's hard to even imagine what you would be, in terms of just personality-wise and also medically-wise 10 years from now. So, again, it really comes down to your circumstances. And what I share with patients when I present this consent form to them is that, let's just say, you are an individual that is 67 years old, let's just say. And you're presented with this and saying, like, the waiting times for your blood type is about, 8 years. So in 8 years from now, you would probably be about 75 years old. But let's just say, during that time, you receive a kidney transplant offer and you had signed this consent form. And it's a situation where, I feel pretty healthy. I don't think I necessarily need a kidney that's in the KDPI, greater than 85% range. I can wait a little bit longer for a KDPI less than 85. And you can say no for the offer. It's totally your prerogative to say no to a potential offer with no penalty to you. However, let's just say on the flip side of that, let's just say you are a patient that is 72 years old and over the last couple of years, you've been on the waiting list and your health has actually declined a bit. And you don't think, you're probably as healthy as you can be for the time being. This may be an organ for you, like if it means 5.5 years of no dialysis while you're, in the greater than the age of 70, that could be a potential boon to you. So again, it really comes down to the circumstances that you are in, and it doesn't guarantee that you only receive those organs. It just opens that other door, right? You already will be eligible for kidneys that are in the 0 to 85% range. Signing this consent form will allow you to be able to have access to KDPI organs that are greater than 85. Now, another thing to mention, I would hope that your transplant center would only be offering you kidneys that are usable. At Stanford, we obviously do not think, to just offer any kidney to patients. If we see that there is a kidney that is not usable, we will decline it and we will say no, and no one will get a phone call. So in the instance that there are organs like this being offered, knowing, I would say just know that the transplant team is very aware why this donor's organ is being calculated as such, and we will move accordingly and present it accordingly, and of course have a conversation with the patient. So you're on the waiting list. Now you have enough waiting time. What happens next? So transplant readiness, again, differs from center to center. For once you do have enough waiting time, or if you are now nearing kidney transplant, there's a couple things that need to happen. Of course, they need to make sure that you are medically, psychosocially, and financially cleared. So at this time, they likely begin moving forward with any necessary tests, any necessary lab work, any necessary follow-up with your caregivers to make sure that everything is in place. And of course, securing information from the insurance companies that it's okay to proceed. So essentially, once all of those things are in place, your transplant center and yourself can feel pretty confident that you can be made active. And again, like I'd mentioned, when you are active, you can receive a phone call at any time. And that's, again, when we at Stanford activate patients, we do have a conversation with them and share with them that you have a couple of responsibilities now that you're active. Now that you're active, please be aware you can receive a phone call at any time. That if you are planning on traveling, please give us a heads up, just because if you are planning to go outside of the area, kidney transplant offers, there are time sensitive. So sometimes there are opportunities for patients to return back from where they are on vacation or visiting friends or family to receive the offer. Sometimes they may be out of the country. In those instances, it's just important for your transplant center to be aware of those things, just so that if an offer does happen to come and you're unavailable or outside of the country, we can move very quickly onto the next patient that may be waiting. That's just kind of the risk that you may need to take. Of course, we also perform regular health updates, or should be performing regular health updates, and of course, updated lab samples, so that if an offer does come, we are performing a cross match at the time of the offer to make sure that you're compatible. All right, so now just a little bit of insight onto that. What does that look like when you receive an offer? So typically, the transplant center will contact the patient and the potential recipient and get an update of their health, saying if there's anything new that we weren't aware of, since the last time we contacted you, like any new cardiac studies, any new hospitalizations, emergency room visits. It's very, very important that you are honest and truthful during this time, because it can dictate, how we kind of proceed regarding the kidney transplant procedure and process or preparation. So that's what will likely happen. And then, of course, the team will let you know what the next steps will be. Essentially, during this period, it's the team's job, and of course, a team's job to make sure that the recipient is coming to and getting to the hospital at the appropriate time, understanding what needs to come with them, and making sure that the organ arrives to the hospital safely, and that all the appropriate testing is performed before the procedure begins. The surgery and hospitalization, now typically, the surgery takes about 3 to 4 hours for a kidney transplant alone, and hospitalization ranges in about the 4 to 5 day range, and then you are essentially discharged home. Seems pretty drastic. I think when I bring that up, sometimes patients are like, do you 5 days only? Yes, 4 to 5 days only. That's pretty much all it takes. And the thing about kidney transplant is that there is, ongoing care and follow-up almost immediately after you are discharged. So for example, at Stanford, we have running post-transplant clinics on every Monday and Thursday. So if a patient is discharged anytime between Monday and Wednesday, we'll see them on Thursday. If they are discharged anytime between Thursday and Sunday, we'll see them on Monday. And then we see them twice a week for the first month, then once a week for the next month, and then once every 2 weeks, and then once a month, and then once every 2 months. So we kind of pull back a little bit with the ultimate goal that you are then released back to your local nephrologist, who will be kind of just doing the very generalized transplant medication care and questions that you may have. Of course, we're always here, and every transplant center should always be available to their patients if you happen to have any particular questions. And then the transplant centers are actually required to see you on an annual basis. Of course, regarding the post-transplant kidney transplant period, Of course, follow-up scheduled appointments will be occurring. There will be an adjustment of anti-rejection medications. That's actually very important because especially during the first month, that's kind of very tenuous time where the team is trying to get to better understand how you are reacting to the medications, to your kidney function, and adjusting the medications accordingly, with the kind of ultimate goal that they get to a point where you're taking medications consistently and routinely without many changes, day to day, and hopefully maybe instead just a couple of times, every couple months. And then, of course, we are always here to support you as a kidney transplant center. Some couple things just in terms of living donation. I know I had to touch those on. Just wanted to really briefly touch on these. Strongly encourage living donation if you have the ability to do so. It can reduce your waiting times on the kidney transplant waiting list. It can, tend to have better outcomes because it's very planned. Where the organ's coming from. We can check for compatibility. We can plan for the surgery, and then of course it can come from relatives, loved ones, and friends that you know. Blood type compatibility is not a requirement, and I'll talk very quickly about the National Kidney Registry after that. And then each program will have their own living donor evaluation process, so just things to keep in mind. So I talked about donor paired exchange. One particular organization that does donor paired exchange is the National Kidney Registry. We utilize that program at Stanford. And what that essentially is that if you are not compatible with your recipient, if a donor is not compatible with the recipient, you can actually be entered in as a pair into the National Kidney Registry or a donor paired exchange program, where then you would be able to swap where a potential donor can donate to a recipient that actually matches, and vice versa, so that living donation can still occur. The beautiful thing about this is that it actually can result in multiple transplants, multiple living donations. And this is just kind of an example of where there was an altruistic donor who was, wanting to just donate to anyone and not necessarily having a recipient in mind, that begins a chain of transplants. So this is kind of just an example of one from a visual standpoint. And this is an actual example in real life of an actual, a cluster of living donations that occurred back in 2012. I bring this example up is because Stanford actually was a part of this chain. So this is just an example of what can occur if you are not, matching with your recipient. There's still opportunities. There's still a way forward with living donation. Please keep in mind that there are a couple things to keep in mind regarding living donation. Of course, there's confidentiality issues. Living donation is a very interpersonal and personal experience, and it's Amy had shared that she was experienced the living donation process as well. And it's a very intimate and also very sensitive process to go through. So just know that there are many things that kind of come into play when being evaluated for living donation, that it is the job of the transplant center to make sure that the living donor is being cared for as well as the recipient. So my living donor team, for example, is always just making sure that they're trying to keep things as confidential as possible and protecting the needs of the donor as well. Understanding that they want to pursue living donation, and the recipient wants to have this donation occur. Some things to keep in mind also in regards to international donors. There is no coverage for out-of-country expenses. Blood kits can be an issue, trying to get blood in and out of countries. And then sometimes there's a very low chance of visa approval for donors to potentially come over. I think that's actually become more difficult given the world circumstances at this time. And of course, the workup process, it's not as simple as many people may think. It is very involved as well. So we try to do the best we can to work patients through the living donor, potential donors through the living donor process, and make sure that if you are going in healthy, that you donate and then leave healthy. So that's just important that, it's a very odd thing and a different thing that in donation, we're actually performing a surgery on a healthy person, whereas surgery is typically reserved for individuals that something needs to be fixed. And so that's a very interesting thing and a different dynamic to kind of always a good thing to keep in mind when going through this process. Okay. With that, that's kind of all I have to share regarding just the very general information about the kidney transplant evaluation process. Any questions at this time? I believe I have now only 5 minutes, Doris. I think is that correct?
That's right, Kevin. This is Patty. There are some questions. We'll get through as many as we can. And then, as I said earlier, we will answer them via in the follow-up email. So the first one is, who completes the CMS 2728 when a renal transplant is achieved? Is it the treating nephrologist or the transplant center?
You said when the transplant is received. Is that correct?
When a renal transplant is achieved.
Achieved, yes. So it's actually the responsibility of the transplant center to perform complete the 2728 form.
Okay, next question. If you don't have liver function within normal range and slightly off, can you still qualify for kidney transplant?
Yeah, that's a great question. Not being a knowledgeable person about liver transplant, if there are indications that a liver transplant is noted during the kidney transplant evaluation process, we typically don't list the patient for kidney, and then we notify the patient they actually may need to connect with our liver transplant team. And then if a kidney is still indicated, then it kind of goes with that primary organ liver and then comes back to us as kidney. So typically in multi-organ situations, the kidney is the caboose of the train, is what my medical director likes to say. And we kind of follow along with those primary organs, those life-saving organs, heart, lung, liver.
Okay, great. Next question is about Medicare. Someone has Medicare and wants to be listed at several different centers, including a few out-of-state facilities with shorter wait lists. Which Medicare option will allow me to do that?
Ooh, I'm not knowledgeable enough about that. So I would inquire with their Medicare office about those questions.
Okay. Patients with high PRA scores or sensitized have higher priority, ? Is there a limitation to which transplant center they can be referred to or participate within a swap?
So to answer the first question regarding this CPRA, so there is a higher priority when it comes to kidney donor offers. As far as I'm aware, if you are, the higher that PRA is, you may have a potential to receive a kidney transplant sooner because of that. But it's only because as your CPRA, and we didn't talk about this during the presentation, but CPRA stands for calculated panel reactive antibodies. And that actually is a calculation of how many antibodies that you have because of sensitizing events like transfusions, pregnancies, other transplants. You get that priority because you are less compatible with the population. And so it's kind of a way for making that transplants are more equitable for even for patients that have those high CPRA levels. Right. I would ask that of your particular center regarding donor exchanges, because again, every center has their type of things about and criteria regarding being entered into the NKR. From Stanford's point of view, at least from the practices that I've seen that we've done regarding high CPRA offers or high CPRA patients, is that if the NKR is a potential option, we do enter those patients in, but we also know that it's going to be difficult to match patients that have a high CPRA. So we know with that knowledge. So we try to work it from both ends, where NKR may be an option, but also making sure that they're ready for a deceased kidney transplant, because it can come from both areas.
Right. All right. I think we have time for one more.
Okay.
Kevin, you mentioned the possibility of getting listed at another transplant center outside the area, like another organ procurement organization area. Didn't UNOS change how kidneys are allocated, making multiple transplant center listings unnecessary unless the center is at least 250 miles away from your current transplant center?
You are absolutely correct regarding the nautical miles in terms of donor offers. There's not, I would say we are still sharing that information regarding multiple listing because that has actually only gone in effect last year. So we don't have enough information to say definitively that it doesn't matter. I think that's actually one of the questions I asked my medical director when those things kind of went into place, is that should we be changing the verbiage and things that we're saying regarding multiple listing? And he said, well, we don't know yet. We can't say for sure that those things have absolutely changed. So even with multiple listing, every center will have their own doctors and their own, way about pursuing transplants. So it really comes down to that. But I would say that it's still applicable regarding potential offers, because 250 nautical miles is additional miles. And I know that, for example, UC Davis does have access to other transplant and other hospitals that they would be receiving offers from that we don't in 250 miles. So it isn't, I would say it's not like, again, this is just me just kind of surmising, but it's I would say still significant enough for any opportunity for you to receive a deceased donor transplant, even if it's a couple more miles, right? So that would be my thought.
Yeah. Well, Kevin, unfortunately, we have run out of time. It feels like we could have you back for a half-day seminar in the near future. Sure. We have many unanswered questions. I hope we can work together with you to get those answered for the email. Sure. But thank you so much for your presentation.
Of course, and thank you again to all of you and for the preparation to do this. This was fantastic, fun. Glad to be here. Glad to be a part of it.
Thank you so much, Kevin. Okay, now it is my pleasure to introduce our moderator for the panel discussion, Navigating the Kidney Waitlist, Becca Chung. Becca is a professional fundraiser in human rights, higher education, and healthcare. She received a kidney transplant in 2016, and in her day job, Becca works for the Office of Advancement at the Seattle Colleges Foundation. And as we've learned, Becca is passionate about all things kidney community. She volunteers her time with NKF here today, as well as Northwest Kidney Centers in Seattle. She's currently the co-chair for the NKC Gala Committee, using her powers as a fundraiser to make a real difference in the lives of all kidney patients. Thank you, Becca, and take it away.
Thank you, Patty. I'm excited to be here today, and I'm so excited to introduce our panelists to all of you today. So for those of you who are with us and you missed the slides in the beginning, we have these amazing panelists with us. We have Nicole, we have Timmy and Perry. If you want to turn your cameras on, we can go ahead and get started. Awesome. Thanks for being with us today. Just for context, why don't we go ahead and do 30-second introduction, so those of us that are here didn't get to see your amazing pictures and your bios can get to know you. So why don't we go ahead and start with Perry. Tell us about yourself.
Hi, everyone. I am currently on dialysis for the second time after a 9-year kidney transplant failed. I was previously on dialysis for 4.5 years prior to that transplant, where I did hemo at home. I carried children before I started dialysis, and I had one post-transplant. So I am in that high antibody category that we talked about earlier with Kevin. I also work for the National Kidney Foundation in Cincinnati.
Thanks, Perry. All right, let's go ahead and jump over to Nicole.
Hi, I'm Nicole Jefferson. I live in Dallas, Texas. I am a 2-time transplant recipient. I received my first transplant in 2008. I received my most recent transplant in 2020 at the beginning of COVID. And with that transplant, I did multi-list. So I was transplanted in Iowa instead of Texas.
All right, thank you, Nicole. And last but not least, we'll have Timmy. Tell us about yourself, Timmy.
Thanks, Becca. Hi, I'm Timmy Nelson. I was diagnosed in January of 2013. I began dialysis in December of that same year. April of 2014, I joined the wait list here in Pennsylvania. And in July of 2017, I received my kidney transplants. I'm just past 5 years post-transplant.
Thank you so much, Timmy. Well, that's a perfect leeway into our discussion that we just had. Thank you so much, Kevin, for giving us that amazing presentation. So I'm curious about all of you. What was your experience getting on the wait list? What worked for you and what didn't? Timmy, you want to go?
Sure, happy to. Sure. I tell you what, the wait list was a great experience for me. In fact, I'll share with you that I learned about the wait list at diagnosis. my nephrologist was one of those kind of nephrologists that just told me everything from A to Z. So our initial discussion, he included some discussion on waitlist and how that process was working. Everything he said was true. I mean, I went into my transplant facility. I spoke with my pre-transplant coordinator, and she shared with me everything that would happen through the process. She talked about the testing that I would go through. She stressed to me a couple of things that I remember through my entire process, is that they can do all the medical things, they can do all the testing for me, but my goal, my responsibility was to be as healthy as possible throughout this entire process, and also to adhere to my dialysis prescription to make me the best possible candidate. So it was very seamless for me.
I love that. Thank you for sharing. That's similar to what my team at the University of Washington Medical Center told me too. Be as healthy as possible, keep going on walks, keep eating healthy, avoid the salt. Why don't we go ahead with Perry next? What was your experience getting on the wait list?
So the first go around in 2007, I was listed. Again, my antibodies were high. So I got listed pretty quickly because I was only 30 at the time, but I had to go through desensitization with apheresis and Velcade so that I could potentially find a donor, which I did. And then this time around, since I'm much older, the kidney transplant list process has been a little more time consuming just because there are additional tests that I have to have that I didn't need when I was 30. So I just have 2 more things to complete and then I'll get listed this time around.
Well, we wish you luck for that. And also, I just have to say, age only matters if you're a cheese. So, and what about you,
wine, right?
Yeah.
So my first go round, I actually crashed into dialysis, so I didn't know a lot of things. So the first time that I got listed, I just listened to what my dialysis doctor said, and that's what I did. I was listed there where I did dialysis. However, there was a big gap in between that first time and that second time. So with the second one, I was able to see, I knew that I could multi-list. So I didn't want to go on dialysis the second time. So what I did was I just listed everywhere. And what I want to say is that at each center, it was completely different. However, it was a smoother experience. And I just believe maybe that's because I knew a little bit more than I did the first time, but it was pretty straightforward.
Thank you. That was actually a perfect transition because, I was going to ask you, did you consider listing at multiple places? And I know we saw some folks asking in the chat about that earlier. So Timmy, do you want to go ahead and tell me about you and how you considered, maybe listing yourself at a few different spots?
Well, I tell you what, I actually went to one transplant facility, and that was because I did a lot of research. I do a lot of volunteer work where I live and with hospitals when I have you. So I spoke with a lot of medical professionals, and we talked about a transplant facility for me to go to. I chose that facility, and the research paid off for me because it worked out well, and I'm very pleased with them, and I was very comfortable with them. Also, I thought about part of my consideration was when you list it in multiple places, you have to consider transportation also. And if you get those last minute phone calls, which I coincidentally did, I get that last minute phone call, and can you get there? And then also post-transplant to go back for your follow-up test. So just something to consider, but I would encourage anyone to do what works best for you and your lifestyle.
That's a great point and something I never had to consider. I just wanted to stick right there with UW and my transplant team. But we have a quick question in chat and I thought we could squeeze it in. If you multi-list, will private insurance cover your testing at multiple centers? Do you know that, Nicole or Timmy, from your experience?
From my experience, I have private insurance, and my private insurance did cover it. It also covered my transportation on because I did get that call at 2:00 in the morning, and I had to be in Des Moines in 5 hours. So they covered that. They covered the jet to get me there. They covered me coming back. They covered my stay because you do have to take into consideration that if you do transplant in another location, you have to stay there for about a month. So I was in Iowa for a month in a hotel. So luckily that was covered with private insurance. However, I will say that each insurance is different because although I work for the same company, my insurance changed a little bit. And with a different company, with a different insurance company within the same company I worked for, my insurance changed and those requirements and restrictions changed in what they were able to do.
Oh, thank you for sharing that. That is not something I considered about having to stay there too, but I'm glad that we have insurance options that can really help out in those instances. I wanted to ask a quick question to Timmy. I have here that, I wanted to ask you where and how did you find out first that transplant was an option for you?
Becca, my first encounter with my nephrologist, and I'm very pleased to say that too, my first encounter with my nephrologist. At that first meeting when everything is spinning and I'm not hearing anything he's saying, I do recall that my nephrologist saying to me what my situation was. He said it's manageable. We talked about my type of dialysis, which was PD. But the other thing that he shared with me at the very beginning, he says, PD is just a step along the process. Dialysis is a step along the process. Our ultimate goal is to get you prepared for transplant. And I tell you what, I felt so encouraged when I look back at that his focal point was not just now, but where we're going to in the future with this.
Oh, thank you for sharing that. That's so beautiful. And it sounds like you had a great nephrologist.
I did.
Awesome to hear. I wanted to give Perry a chance to speak. Did you have any guidance on finding a living donor? And how did you share your need for finding a kidney in the first place? Oh, we've got you at mute, Perry. There you go. You're good now.
Well, the first time around, transplant centers really weren't encouraging people to ask for a living donor. Mm-hmm. The second time around, and my past history with working in programs here at NKF, I learned a lot about the big ask, the big give. And so I learned in that process that you don't necessarily have to ask for a kidney. So kind of immediately once we found out that my kidney was failing this time around, I started sharing what was going on Facebook, and it ended up that through sharing my story, a friend of a friend who read it on Facebook went ahead and donated a kidney through the Paired Exchange Program, the NKR. And so I currently have a voucher waiting in that program once I finish my testing.
Thank you for sharing that. That is so amazing to see how social media and connections and friends and people you don't know can really come through and, support you. So,
right.
Yeah,
and you don't have to ask. It's just
absolutely
sharing your story, and the people who want to help will come forward to help.
Absolutely. Thank you for sharing that perspective. And Nicole, I wanted to ask you that too. Was there guidance that you received, especially on, I know there was a follow-up question I wanted to also ask you in chat. So Amelia asked if anyone had, Barbara. She asked if there was a support person that flew with you, but then also backtracking, how did you share your need for a kidney in the first place to your community?
Sure. So just to do the support person, I did have a support person fly with me. My daughter flew with me, and I had to have someone up there for the month. So my daughter and my mother took turns being that support person, flying up and flying back. However, we have to remember this was in April of 2020. So they were trying to figure out COVID, trying to figure out what they could do. So there were restrictions that they kept changing and going back and forth. So it was just a really weird time doing that. But back to the sharing my need. I did share on Facebook that I needed a kidney, that it was going out. So I did have some people who tried to donate, and they were anonymous. And then I had, my daughter's best friend from childhood. She attempted. We weren't a match, but she was open to the swap. However, I just, was still listening, still doing everything I could, just because at that point, my goal was to avoid dialysis altogether.
Absolutely. That makes sense. Thank you for sharing those answers, Nicole. So moving on, we've talked about KDPI, which is the Kidney Donor Profile Index. So I'll have to thank Kevin for explaining that to us earlier today. Timmy, do you want to give your example or your experience in were you offered a higher KDPI kidney? And do you remember that being discussed? Was that offered? Was that an option for you?
It was, Becca. And in fact, I'm going to go again. You're going to hear a common theme with me. My nephrologist, I just think the world of him. He covers so many things, and he did it repeatedly, which I think is important to share also, is that when you're speaking with you about something that's life changing, like ESRD and the possibility of a transplant, it's so important to share information over and over again till the patient understands it. And my nephrologist did that. So when I went to my transplant coordinator to have a conversation about the whole process, as she spoke with me, one of the things she shared with me was about high KDPI kidneys. And she explained to me, you know, pretty much what was shared earlier today. She explained to me that here's a kidney that it maybe have some challenges, was the word she used, but it's perfectly acceptable for you. She says, so as we get closer to that time, we'll discuss that with you. But she asked me, she said, what are your thoughts right now? And my response was, because of the confidence I had in this transplant center, is that if you all tell me this is something I should consider, I'm happy to consider it. We'll talk about it when that time comes. So it was a great conversation. It was very inclusive of me as a patient.
Thank you so much for sharing that. I love that it seemed empowering, at least from what I've heard, that they asked you, what do you feel about it?
Yes.
And is it safe? And that you had a really safe conversation around that. And I think, you know, there might be fears of the unknown, at least for me, when I first learned about that, you know, that I needed a transplant. I didn't really understand what a KDPI was. I still keep looking at my notes on the definition, you know, and so you being able to dispel that and just kind of say, hey, it's a conversation with my nephrologist and my team is really encouraging. And Nicole, sorry, you just went off camera. But if you would like to answer that too, were you also offered one? Or Perry, you as well. I know that, you know, a living donor was in the cards here, but I have Nicole's name down. So let me know your thoughts.
Yeah. So when I first went on this, when I was on this, I did receive a high KPI the first time. The second time, my nephrologist told me, don't take one because I had time. It was 2016. So he told me, you know, just wait. However, as time went on, I was nearing dialysis. I decided to take a high KPI. So with this one, I did take a high KPI, but this has been the best kidney I've ever had. I feel better than I have felt since before dialysis. I mean, since before I even was diagnosed with CKD. So, you know, I suggest and encourage people to go after the high KP. I can never get that together. To go after those kidneys and get them. That also played into when I was listing and where I was listing. In Iowa, Dr. Chaudhry, he tends to take kidneys that other people don't want to take. My kidney actually came from Washington. So it had gotten passed over by a lot of different places to get to Iowa for me to come get it. I actually beat my kidney to Iowa. So a lot of people didn't want it, but it has been the best. It's been the best. So yes, I was offered, and yes, I accepted.
I love that. Thank you for sharing that with enthusiasm, because you know what, sometimes we need a reminder that, hey, it's a transplant. That is a gift. You get that kidney, and that is better than being on dialysis. So thank you for sharing that. We have a question from Monica in chat on how do you avoid dialysis, and is the patient referred to a transplant by their nephrologist? And then can they be active on the wait list before even being diagnosed with ESRD? So I'm not sure if we can answer, maybe we can answer the first part. I know for me, I tried to avoid dialysis as long as I could. And, you know, my nephrologist said, hey, stay healthy. It's just like what Timmy's nephrologist told him, you know, keep going on your active walks per day. You keep eating healthy, and we'll get you on dialysis last minute. But I didn't get on dialysis until I had a 5 GFR, I believe. So what are your experiences on that, Timmy and Perry?
Well, I tell you, Nicole, Becky, mine was kind of similar to yours, I think. I was diagnosed in January of 2013, as I stated. I didn't know, I had no symptoms. I was asymptomatic, had no symptoms at all. So when they discovered I had ESRD, I was at stage 3. A month later, April of that year, I was at stage 4. And my nephrologist told me then, he says, by the end of the year, we're gonna have to put you on dialysis. He says, but until then, he said, if you keep doing the things I'm asking you to do, we can stave off that time. He says, so the longer we can wait before we put you on dialysis, it's good for you, obviously. He said, plus you're developing some habits you're going to follow the rest of your life anyway. So, like you mentioned, Becca, the walks. I mean, like, I'm not a marathon runner, okay, but a good brisk walk does wonders for your body. Okay, eating right, eating healthy does wonders for your body. Some basic things that we all need to do, and those are the things that possibly kept me from going on dialysis for almost a year once I was diagnosed.
Wow. No, that's great. Thank you. Was there anything you wanted to add to that, Perry, too? We're good. All right, let's move on.
Yeah. So I was just going to say, just don't be afraid.
Yes,
I know before you get the diagnosis, it's a lot of information to take in. My nephrologist first time around said in about 2 years, your labs are trending that you'll have to start dialysis or receive a transplant. So he was ready to have that conversation earlier on than I was. After that, I went into denial. And so I would just encourage everyone to take the information, absorb it, have your pity party, but then crawl out quickly so that you can get the information that you need to hopefully get a kidney before dialysis.
I love that. Thank you, Perry. I love that empowering acknowledgement of you can feel all the feels and then you get right back up, and what's next? Bring it on. So speaking about what's next and transplants, did you have any reservations about receiving a transplant in the first place? I remember what I felt when I first found out I had kidney failure and needed one. And what were your initial feelings when you found out that you needed a transplant and that was the route to go? Timmy,
Becca, it was.
Yeah.
I tell you what, it was devastating, no question about it. And as I share with folks, as I share my story, is that my life flashed before my eyes, so to speak. And my doctor recognized that. My nephrologist recognized that, and he gave me some time to gather myself. He said, "I'll be back, and we'll talk about it." He came back in, and the watershed moment was kind of subsiding, and so we talked. He said, "Now let's talk about what we need to do to get you where you need to be." And so he allowed me that time to quickly grieve, if you would, on my situation, but then he turned it into a positive and said, "Look, here's the things we can do. You need to work with me. We'll work together, and we'll make this work out for you." And so he took that negative that many people would see and turned it into a positive for me. And the only reservation I had was, tell me all the things I need to do, and how quick can I get a transplant? That was my focal point then.
I love that. And thank you for sharing your first mood and reaction. I think that's something that should definitely be embraced and talked about within spaces like this that are safe, because the human emotion and the first reaction about, oh, you need a transplant is a part of the entire process. So I appreciate you answering that first. And Perry, would you mind sharing your experience that, hearing this too?
I think back when I was initially told that I would have to start dialysis or receive a transplant, I was in complete denial. And then when I ended up with gout in my big toe, I had to go to the emergency room because I thought I had broken my foot. And the urgent care doctor said, "That's not broken, but I'll take your money and give you an x-ray." And he came back and said it was gout. Did I have any previous kidney issues? Which I had. So I went and had labs drawn and found out that my kidney was only functioning at 4%. The ER doctor told me, doctor told me, "Have you been tired?" And I said, "Well, I have 3 kids. I'm
so
always going."
Especially tired, maybe.
Right. And he was like, "Well, you don't look this sick, so we're going to rerun the labs." And he came back and said, "Sure enough, you're going to have to get a catheter and start dialysis tomorrow. We're surprised that you're still coherent." So that almost 2 years of denial really did a doozy on me. So once I was told that, I was lucky to be alive still. I decided that it was kind of like being strapped into a roller coaster, and you either had to laugh and make it the best you could, or you could scream your head off, but that's just going to give everyone a headache. So I decided that I was just going to do my very best to make it the best experience for myself and everyone around me. I also looked at it like others were watching me. And so I was going through the experience, not just for myself, but somebody else was watching me. So So I had to be a good role model, basically. That's how I looked at it.
I mean, I'm inspired here. I think there's, the 120 plus people on here are also listening, and they have their own stories connected to this too.
Absolutely.
So that roller coaster, example is so real. At one point you just have to decide, all right, I'm buckling in, I'm going for the ride. So thank you for sharing that.
Becca, not to go off script real quick, but just to highlight something Perry just said, and I think we as patients have to do a better job of this, is that we have to tell our stories. And because there are other patients that are wondering, they're going through the same things we went through. And for us to tell the stories and show them that, guess what? It can work out well for you. Tell the positive stories, because they only hear the negative stories. Tell the positive stories, and that's the encouragement. That's where the encouragement comes from.
And you do have bad days. Yes. I mean, everyone has bad days, even when you don't have kidney disease.
Yeah.
But you just, like I said, you can't live there.
Yeah.
You can visit your downtime, you can be sad for a minute, but you have to pack back up and move on.
Absolutely.
Yeah, just like Timmy said, so when I was told I needed a transplant, I crashed into dialysis. So I went to the emergency room, started dialysis the very next day. So I knew I needed a transplant. So it was a whirlwind of emotions. So I wasn't able to get, coddling or anything like that. However, what I do is I try to make sure that I'm encouraging to other people when it happens. And it's interesting because about 2 days ago or so, I was referred to someone who had an issue. And so this young man, George, and he was upset that he was told that he had to start dialysis and he needed a transplant and try to avoid dialysis. And he was upset about that. And, I just told him, tried to give him some encouraging news. And it was so heartwarming for him to call this morning after, we had been talking about, telling him how to get listed. And this morning when he called, I was like, wow, you seem to be in a very good mood. And he pretty much said the same thing. He was like, you know what? I can't, just let this go. I have to keep moving. And so now he's positive. We're going to get this kidney. We're going to, go forward. So because I didn't receive that necessarily, I try to make sure that I do provide that for others.
I love that. I love the realness you three are giving. And I'm seeing some really encouraging and positive connections and notes in the chat too. So thank you, Timmy and Perry and Nicole, for your vulnerability with me right now. So moving on, we wanted to go back to, talking about the transplant process. So were you told about the option of getting a preemptive transplant? I know we've talked about dialysis a little bit. So Nicole, if you would like to continue, were you told about this option?
Sure. Like I said, the first time, since I crashed into dialysis, I didn't even have any idea that I had kidney disease. I was one of those 1 in 3 that walk around not even knowing I had kidney problems. So of course I wasn't able to be told at that point. However, I was made aware the next time that I didn't have to go on dialysis. And a lot of people seem to think you have to be on dialysis to get a transplant. And I knew that just was not the case anymore. And so at that point, I was told, but I was just actually told by people in the community. A good friend of mine, Kevin Fowler, he had a preemptive. Yeah, everybody knows Kevin. So Kevin told me about it. And so from there, it just gave me hope. And I understood that, you know what, nobody has to go on dialysis if you, can do it or get it early enough.
I love that. Thank you. Perry, did you want to share? Were you told about the option of getting a preemptive transplant?
I was. So the first time around, like I said, I went into denial and did not do that. The second time around, we unexpectedly found out that my creatinine had jumped from 0.7 to 13. And we had just thought it was a sinus infection that was happening. It ended up being kidney failure. So at that time, they had done some things to reverse the rejection, and they were waiting to see if they could hold it off long enough to try and get a kidney transplant. Right. Unfortunately, I was deathly ill that time around, so they went ahead and started dialysis before I could get listed.
Okay, that makes complete sense in that situation. So, and so for the rest of you, well, the rest of you meaning Timmy also, what were you told to expect before receiving your transplant?
You know what? That was a lot of transparency also for me. one of the things I was told is that, a kidney transplant is not a cure for ESRD. It's a treatment choice. Okay. It's not guaranteed. It's not guaranteed to last forever. And that's when my medical professionals start going back again to, but here's what you can do. Okay. We can take care of the medical stuff, but you need to keep doing the same things you're doing that will get you to the point where you can get a transplant. You got to take care of yourself. You got to have your medical appointments, and you have to get thorough medical appointments. You need to make sure that all of your medical professionals, all your doctors, my dentist, my eye doctor, my podiatrist, everyone, my dermatologist, they all know what's going on with you, because when they all know what's going on with you, then we all work together as a team, and you're the captain of your care team.
I love that. It seems like we have a fan. We have many fans here today of your nephrologist, because you keep talking them up. I feel like I need to talk my nephrologist now. So Elizabeth in chat from the ESRD Network 5 is interested in knowing who your nephrologist is. I don't know if you want to maybe direct message them on the side, or if you want to share that, but it looks like your nephrologist is inspiring.
Sure. My nephrologist, his name is Dr. Stephen Hahn. I live in Westchester, Pennsylvania. But Dr. Stephen Hahn has done an amazing job. In fact, I'm going to see him in 2 weeks for another checkup, but he's just amazing, and he encourages me every step of the way.
I love that. Thank you for sharing that. And how about you, Nicole? Were you told to expect anything before your transplant as well?
I was told to expect to feel a lot better. And honestly, that was a lie. I didn't feel better the first one. And, one of the things that I do is I just want to tell everyone just the real deal. And the first transplant, I did feel better. I didn't feel better for a long time. I was transplanted in 2008. I didn't start feeling better until probably 2011, 2012. And then it failed in 2016. But again, this second one that was high risk, very high risk, day one, I was like, whoa, what is this? How am I feeling? This is strange to me. So, but actually the thing is, the doctor did tell me with the second one to expect not to feel, he told me that it would be rougher for me because it was my second one, but it was completely incorrect. But that goes to where people are talking about numbers in the chat. Please, please, please remember, numbers are just averages and thoughts based on statistics that they have. They aren't based on statistics that they don't have. So your situation is going to be unique. It'll be different. So don't plan based on what people are telling you. Just wish for the best, hope for the best.
Well said, Nicole. Thank you. We've got some really good questions coming up as we slowly come to a close. Looking back, what do you wish that you had known about the transplant? So we've just talked about what were you told ahead of time, but what did you wish you knew ahead of time? Nicole, did you want to continue on that one?
Sure. I wish I was told that it wasn't a cure, because the first go around, I thought I was cured as a lot of other people. I didn't know it was just another form of treatment. It just means I didn't have to do peritoneal every single night. I also wish I had known, and this is up for controversy, but this is my story. I wish I had known that I was going to take on these personalities and start liking the things that these other people they like. So yes, I have characteristics. I have I woke up wanting Diet Dr. Pepper and Rice Krispies, and I was like, why do I want this? The first time, I don't like this, and I've been drinking it ever since. Second transplant, I woke up, I promise, I woke up with a lot of gray hair. It's like, oh my gosh, this person must have had gray hair. I mean, it literally went from just overnight. So when I got a mirror, I was like, uh-oh. But yeah, I just, those are the only things. Other than that, I did a lot of research.
Thank you. Oh, that is fun. I saw all of you smiling. So Perry, Timmy, why don't you go ahead? Perry, let's start with you.
I'm going to jump back to your previous question. I wish they had told me that the medicine they give you after transplant isn't a one and done prescription. You're going to spend that first year with them adjusting, readjusting. And also, I think there's not a lot of talk about the emotional side of receiving.
Oh, we're losing you just a little bit, Perry. Come back. Repeat that again.
Okay, I was just going to say that there's not a lot of talk of the emotional side of receiving a transplant, whether it's from a living donor or a deceased donor. So I would encourage you to find patients like one of us or someone that you're comfortable sharing with, that who has also been through it. I think that's very important. And like Timmy said, you want to advocate for yourself, but you also want to find a healthcare professional who you feel like you can open up to, because the only way that they can really help you is by knowing fully what you're going through, what you're feeling, how medicines are affecting you, how you're feeling on dialysis. And I personally have been shut down by physicians before. So it helps if you find a social worker, a dietitian, a nephrologist who is willing to listen to you and actually be on your team, like Timmy said.
To be like your personal cheerleader. I love that. Yes. You're absolutely right. Just like Timmy's nephrologist. So Timmy, what do you wish you knew going into
this is a tough one for me. This is a tough one because I got to tell you, my personal nephrologist, I mentioned Dr. Stephen Hahn, and then my University of Pennsylvania nephrologist, Dr. Marianne Lim, they're like a tag team with me. They are. I mean, and I tell you what, I can't answer that question, to be honest with you. I can't think of anything that they should have or could have done differently, because I feel so informed about everything, every step of the way. I have no complaints or concerns in that area. And I tell you what, I guess I'm just a blessed guy to have both of these two nephrologists on my side here.
No, that's amazing. I love that you were so prepped going in. But I wanted to take a moment and pivot back to something that Nicole just wrote in chat. That you went through years of mourning when the first transplant was failing. I want to acknowledge that, because I think all of you are right. Sometimes we need to address the emotional aspect of having a transplant. I thought once I would get my transplant, and I had a living donor and I'm very close with her now, we are colleagues, that all my problems would go away and I'd be fine. But I had a lot of issues after. I had to adjust my tacrolimus levels over and over and over again, and I kept getting sick and I had to go back to the hospital a few times. And so there was this emotional part of, I can't share with my network that I'm still struggling and that it hurts. And I hate going back to the hospital.
You should be happy, right?
I should be happy and thankful. I had a transplant. I had a living donor. And so it's really good to acknowledge that there is a huge emotional component that comes after transplant. So thank you, Nicole, for sharing that in the chat. So I know we're kind of on this topic, but what surprised you about getting your transplant, and was it different from what you expected? We've talked about some of the negatives a little bit, and I want to obviously ask you, what were the best positives?
For me, the best positive the first time was not having to do dialysis. During the time when I was diagnosed, I had my daughter was in high school, early high school. And so by the time I received the transplant, she was in college. So before, I was having to have all of my dialysis supplies sent to the college, when I would go visit, which I did often. And so it was just being able to actually not have to connect myself at night, not having to disconnect, being able to just fly free without having all the supply. So it was almost like if I could jump up and do a jump kick, I would have done that.
Well, you're on camera now, so
yeah. I felt liberated. I felt free. And that's hard to explain to someone who's never been on dialysis or who needs a kidney, but I felt free.
I love that. Thank you. I feel that through the Zoom chat right now. And what about you, Perry? What were your feelings?
I would say the greatest thing was I felt better than I had ever felt my whole entire life. Prior to starting dialysis the first time, I was feeling bad, but didn't really know it. And then being in center dialysis, I felt a little bit better. With home hemo, I felt great. I was off my binders. I was off my blood pressure medication within the first week. My fluid restriction was lifted. So I thought I can do this for a while. And then after the transplant, I think probably a week and a half into it, I was staying up until 2 a.m. I was waking up at 6 a.m. I was ready to go do what I wanted. I was free. I wasn't hooked up to the machine. Had all these extra hours in the day. So I think that was probably the best part about it. It just kept getting better. I just kept feeling better.
I love that. Thank you. Well, we have 2 minutes left, so I want to finish with a great question. It's my favorite one, and I want to give all of you a chance to answer it. What would you tell someone who is new to their kidney journey? And what was the best / worst piece of advice? How about let's go low and then we can go high. So we'll finish like, bad piece of advice. And then the best piece of advice that you have received and that you want to share with those in the crowd today. So Timmy, why don't you go ahead and start us off?
Sure. Let's go with the best piece of advice for me. When I started doing peritoneal dialysis, I had to travel to meet my nurse because she's at a different facility. And so I went into this facility to meet with her, and I had to wait. I was in the waiting room for a while. And this is the first time I really got scared, because I'm in the waiting room and there's a lot of people in the waiting room that have either come out of dialysis or going back into dialysis. And it was not a good experience. They were not happy people. They were grouchy. They just weren't happy. And I'm kind of an upbeat kind of guy, you know? And so I'm sitting there and I start getting nervous. I'm thinking, okay, I want to start dialysis. So I go in to see my nurse, and my nurse, Jen, she's my angel, okay? And so I go see Jen, first time I met Jen, and she starts explaining to me peritoneal dialysis. And I said, Jen, before you start that, I got to ask you a question. Here's what I just experienced. Am I going to end up like that? And Jen looked at me straight in the eye. First time she's ever met me, straight in the eye. She says, only if you choose to be.
Ooh,
and I have carried that with me ever since. So it's not the circumstance, it's what I make out of it. And I encourage everyone that as tough as this may be, and it is tough, you know, you're going to have tough days, you know, but it's what you make. You are not your ESRD.
I love that. Ooh, preach. Love it. Thank you. Thank you, Timmy, for sharing that. Nicole and Perry, I want to give you a chance to be able to answer that too. So let's just stick to the best piece of advice, and then, you know, that you'd like to share with those on the crowd.
I guess I didn't really receive any advice because I was one of those patients that Timmy's talking about who was upset, angry, depressed. So I didn't talk about it. But I wish George could have been here because I've been preaching to George for the past couple of days. I'm sorry, but George would tell you, I'd say, be patient. It'll come. It'll happen. You can live. You can have your life. This is enjoyable. You'll find your way. It'll happen. So that's what I say. Just be patient. It'll happen.
Thank you. Last but not least, Perry.
I think probably the biggest piece of advice is just be willing to share your story and take each day as it comes. Like Timmy said, there's not going to be great days. Short story about myself. While I was pregnant post-transplant, I kept praying, like, please just let my kidney and the baby be okay. Please just let my kidney and the baby be okay. And had a C-section. And then 2 weeks later, I ended up with blood clots in both my lungs. So the moral of that story is what you think's going to come after you and get you is probably not what's coming after you to get you.
Wow.
But you just have to look at every day as a new beginning and try your best that day. Like I said before, not every day's going to end up the way that you want it, but eventually, like Nicole said, you'll get there. Just got to be patient.
Great piece of advice. Thank you all so much for being on this panel with me. It was such an honor getting to know your personal story. Thank you for sharing with everyone that's joined us today. It's been an honor hearing you and being inspired by you. So I'll give it back to Patty.
Well, thank you. My heart is full. What an incredible panel, and really appreciated Kevin's presentation. I want to call out my colleague Doris Liu, who worked with an amazing planning committee to pull this all together. Great job. Again, just thank you for bringing, you brought your whole selves, not only the panel, but everyone in the chat. Really amazing exchanges. And we will be in touch. Please give us some feedback in the survey. Thank you to Satellite Healthcare for sponsoring this great program, and stay safe, and we hope to see you next round. All right, everybody, have a good afternoon and evening.